Good evening everyone. It's a great pleasure today to be a part of this session, and today we are starting from the role of hypertrophy and reverse remodeling in heart failure. And as everyone knows that myocardial remodeling occurs in heart failure with low ejection fraction that involves changes in the cardiac structure, in the myocardial composition and myocyte formation, and multiple biochemical and molecular alterations occur. And we see that this impacts the heart function and its reserve capacity. The understanding of the features of myocardial remodeling has become a major objective for limiting or reversing its progression. So we begin with a case scenario in which there is a patient, Manjari, 65-year-old patient with heart failure with reduced ejection fraction, and this patient had CABG done 3 years back and recently hospitalized due to acute heart failure event. From last few weeks she was complaining of difficulty in breathing and difficulty in doing her day-to-day work. Recently she fell unconscious and was rushed to the hospital immediately. Currently she is on ACE inhibitors, beta blockers, diuretics and MRA. So the clinical history and investigation revealed that the ejection fraction was 32%, GLS 15 and pro-BNP was 1782. Serum creatinine was 2.5. 2D ecography revealed the LVED was 82, LVES was 44 and left atrium volume was 38 ml. So after hemodynamic stabilization, which would be the right treatment for the heart failure with reduced ejection fraction in this patient to improve the cardiac structure and function of the patient? Question is, does the cardiac remodeling in heart failure with reduced ejection fraction patient affect the outcomes post CABG? This is a very important question, that before we take up a patient for CABG, and if the patient is having reduced ejection fraction, then what immediately comes to our mind is that how much muscle is infarcted, how much muscle is hibernating, how much is the stunned muscle and how much is the myomed muscle. So depending on all these factors, the recovery of the patient is decided, and we have to plan what immediate steps we should take before we take up the patient for revascularization for a CABG. And then we have seen that there is an extensive left ventricular remodeling which does not allow the viable myocardium to improve in the left ventricular ejection fraction after revascularization. And this leads to worse outcome after the surgery and the prognosis may be bad. So we assess the patient on echocardiography, and then when we have doubt whether some part of the muscle is really infarcted or is it hibernating, which may later on improve after we revascularize the patient. And if there is still any doubt on echocardiography, then sometimes we resort to maybe a PET scan to see the viability of the muscle. And once we decide to take the patient for surgery, then we look into a few parameters, which they are met, then only we will take the patient immediately, or maybe sometimes we have to optimize the guideline directed medical therapy and we have to optimize the patient's parameters so that the patient may have a better outcome during surgery in the post-operative period as well as in the follow-up, immediate follow-up as well as long-term follow-up. So we have seen that adverse event rate increases in parallel to the LV and systolic volume post revascularization, and it has been seen that the event rates increase 37% in patients with LV and systolic volume of more than 130, and if it is more than 160, these events rate increases to 53%, and in a volume above 180 it increases to as high as 63%. And if the left ventricular and systolic volume is increased, the likelihood of improvement in left ventricular ejection fraction decreases post revascularization. It has been seen that the post-operative ejection fraction may not improve as expected if there is too much dilatation of the end systolic volume. So the risk of mortality remains high in patients with reduced ejection fraction even after undergoing percutaneous intervention or CABG. And the risk of primary outcome in patients with reduced left ventricular ejection fraction post percutaneous interventions at 3 years was higher compared to heart failure with moderately reduced ejection fraction as well as those who had a preserved ejection fraction. So those patients who had an ejection fraction less than 40%, they had a worse outcome compared to those patients who had ejection fraction between 40 to 49% or more than 50%. The increased risk of mortality and heart failure in patients with severely reduced left ventricular ejection fraction post revascularization is very apparent. And here you can see in this data from a cohort study performed in which there were 12,000 patients. The risk of mortality and heart failure hospitalization remained high in heart failure with reduced ejection fraction patients even post percutaneous interventions and CABG. So it was seen that the death rate was higher than in a normal risk patient, and also it was seen that if we compare to percutaneous interventions in those patients who had multi-vessel disease, there was a significant less mortality in patients who underwent CABG. And also the risk of heart failure, hospitalization, post revascularization was also high, but it was less in post CABG patient compared to percutaneous interventions. And also it was seen that if we compare the death rate, that was also significantly lower in the CABG group compared to percutaneous interventions, and also the heart failure hospitalization, that was also lower if we compare after 5 years. So it was similar outcome was seen after surgery within 30 days, and the same result was seen after 5 years also. So CABG had slightly better outcome compared to percutaneous interventions at 30 days after surgery and also 5 years after the revascularization. So heart failure patients undergoing revascularization represent an important population at risk for death as well as rehospitalizations, especially because of recurrent heart failure or worsening of the heart failure. And this was seen even in those patients who initially had a recovery and who had improvement in the ejection fraction. Even we operated patients with low ejection fraction of about 15%, and later on the ejection fraction improved to even normal. But if the patients, they were lost in follow-up, and if they were not following the guideline directed medical therapy, and if they were having some recurrent events, many times they had to come in emergency with again reduced ejection fraction. And then these patients, they had multiple readmission because of heart failure, and the cardiac adverse events rate was also higher. So we want to emphasize that revascularization is not the end of the treatment. So we have to optimize the patient before revascularization, we have to optimize the medical management after revascularization in the ICUs, and we have to continue to optimize in the follow-up period also. So those patients who are on a regular follow-up, they have a better long-term outcome also. Question is, what is the role of sacubitril valsartan in heart failure with reduced ejection fraction patients post revascularization? So it has been seen that medical therapy is very essential for patients with reduced ejection fraction post revascularization as well as pre-revascularization, because when we plan a patient for surgery, it is very important to optimize the patient before taking up the patient for revascularization. And we are doing all the revascularization on beating heart, and which has given very good results after surgery, because initially in the beginning of my career, when beating heart had just begun and patients were being done on pump, after CABG, like with low ejection fraction, sometimes we used to have in weaning off the patient from the pump, and also in the post-operative period, like the incidence of prolonged ventilation and the need for inotropic support was much higher, and sometimes patient used to have renal complication or neurological complication also, and sometimes the heart used to swell so much that it was difficult to even close the chest, and there was sometimes a hemodynamic collapse after we closed the chest. So this thankfully, like when we started doing the cases on beating heart, there was a drastic improvement in the post-operative as well as the peri-operative outcome of the patients, and we have been operating patient as low as 15%, 20% ejection fraction, and with very good results, and not only immediate results, the long-term results have been also very good. So the guideline-directed medical therapy should be considered for all these patients, even before taking up for surgery and during surgery, as well as in the post-operative period in the ICU, and then when we discharge the patient, then we call the patient after surgery for a follow-up, maybe after 1 week, and then later on after 1 month, then after 3 months, and then after every 3 months for the first year, and subsequently, depending on the condition of the patient, at least 3 to 6 monthly follow-up. And we have seen that most of the stent myocardium that recovers within 3 months, and the hibernating myocardium may take 12 to 14 months to fully recover, and we repeat the echocardiogram after 3 months after surgery, and then we repeat after 12 months after surgery, and we find that many times the patients who had adequate hibernating and viable myocardium, they have even complete recovery of the left ventricular ejection fraction. And guideline directed medical therapy plays a very important role in improving the ejection fraction as well as in improving the long-term outcome of these patients. So when the ARNI came into the existence in India, like there was very little data available in post-CABG patients. Most of the trials, they have been done on either medically managed or maybe percutaneous interventions, and there was only few cases at CABG, and those were taken out from the trial data. And when we wanted to really make use of ARNI in the post-operative period, and we initially started using ARNI, we were very much encouraged by the very good results. But main issue was that those patients who had a very bad left ventricular ejection fraction, and those who had difficulty in even maintaining their blood pressures, who had low blood pressure, so initiating ARNI before surgery was like really a very difficult decision, because the patient even didn't tolerate a dose of 25 milligram, what to say of the normal dose which we give to the patient. So we had to sometimes defer the surgery and try to optimize the drug in the pre-operative period, and sometimes even if they were not tolerating in the pre-operative, then in the post-operative period, once the inotropes were off and the patient was ambulatory, it was seen that it is the best time to initiate the drug and monitor the patient in the hospital, because if we discharge the patient and then we prescribe the drug, then patients sometimes they have hypotension and they may come in the emergency because of hypotension. So the guidelines also came up, and in the European guidelines, which was in 2017, it was seen that ARNI is recommended as a class 1B indication as a replacement therapy for ACE inhibitors in ambulatory patients with reduced ejection fraction in the post-operative period. So in 2021, the European Society of Cardiology recommended that ARNI should be given as a first-line cornerstone therapy for all patients with reduced ejection fraction. And it was seen that ARNI may be considered as the first-line therapy instead of ACE inhibitors in these patients. And also we can initiate ARNI in those patients who had a ACE inhibitor given de novo, or patients with who were hospitalized. It was seen that this is the safest period to start the therapy with ARNI so that the patient's hemodynamics can be monitored. And once the patient was tolerating the required dose, and then we can discharge the patient and follow up the patient closely in the follow-up period. So recently in the ACC guideline also in 2022, it has been recommended that ARNI can be given as the first line of therapy for all patients with reduced ejection fraction, and in chronic symptomatic patients with reduced ejection fraction with NYHA class 2 or 3 who tolerate ACE inhibitors or ARB, it can be given as a replacement therapy. And also ARNI is recommended as a de novo therapy in hospitalized patients with acute heart failure before discharge. ARNI has now become a very important weapon in our armamentarium, especially in patients who had reduced ejection fraction, and their post-operative results has been very encouraging, and the long-term results also has been very good. So now we consider ARNI as a very important, I think one of the most important part of the guideline directed medical therapy. So ARNI reduces not only the risk of death but also the heart failure hospitalization in patients with reduced ejection fraction, and this is seen in the post-operative period that they trend towards 26% reduction in the risk of death from cardiovascular causes or hospitalization for heart failure with the use of ARNI has been observed in patient compared to enalapril. So the results have been very encouraging in comparison to enalapril. And also it has been seen that there is a trend of 19% reduction in the risk of cardiovascular death with ARNI, which was observed in comparison to enalapril. So therefore ARNI has now become the most preferred drug in the post-operative period also compared to enalapril. Let me summarize that initiation of ARNI in the hospital who are living with impaired cardiac structure and are at risk of adverse events not only improves the ejection fraction, it also improves cardiac structure, it reduces the risk of mortality and also reduces the risk of hospitalization again and again. And apart from that, I would like to add that even those patients who have significant mitral regurgitation, we have seen that the mitral regurgitation also improves significantly in patients who are put on ARNI, who are initially having heart failure with reduced ejection fraction. So there was an improvement in all these parameters in those patients who had come with heart failure with reduced ejection fraction and who had a CABG. We had a drastic improvement in their post-operative LV function and all these parameters. So I would highly recommend that all surgeons, they should not feel apprehensive in using the drug ARNI in patients with low ejection fraction who come with heart failure and then they undergo revascularization. So this is a very important tool in the other guideline directed medical therapy, and we should use it very frequently with confidence.
Thank you so very much to all the panelists, Dr. Deepak Puri, Dr. Anwar Khan and Dr. Manish Singla. Thank you so very much for a great collaboration and a great talk. So I think there is one question in the chat box. So over to you all, that in patients with MR, what is your opinion on using mitral clip and Does army have any impact on such patients?
Actually, I have already answered a part of this question that in those patients who came to us with heart failure with reduced ejection fraction as well as mitral regurgitation. So before taking up for surgery, we try to optimize with the guideline directed medical therapy, and ARNI is a very important drug in this. And when these patients were put on ARNI, there was a improvement in the not only in the ejection fraction, also in there was a reduction in the mitral regurgitation. And once the mitral regurgitation is moderate, then if we do the surgery, these patients they have a very good post-operative recovery. And if the patients are followed up, we have seen that after 3 months and after 1 year, there is a drastic reduction in the mitral regurgitation. Like, suppose we have a patient with severe mitral regurgitation, we optimize the patient, reduce it to moderate mitral regurgitation, then we take up the patient for CABG, and then in the follow-up, we have seen that it reduces to mild or even trivial mitral regurgitation in the follow-up period. But if we take a patient of severe mitral regurgitation for CABG, so then the outcome is not good. So we would like to optimize the patient first and then take up for CABG, and the outcome is good. And regarding mitra clip, so we have not been using mitra clip in patient with heart failure with reduced ejection fraction in our setup.
With your permission, sir, can we close the meeting, sir?
Sure, you can close. Thank you so much,
Thank you
Dr.
very much,
Anwar, Dr. Manish.
Thank you, Dr. Anwar. Thank you very much, Dr. Puri, for such an interactive.
It was nice interacting with you and hope to see you again. Thank you so much.
See you again, sir.
Thank you.
Thank you. Thanks, sir.